Imagine holding out your hands,
Yeah.
um, palms facing the ceiling and trying to make a tight fist.
Right.
You squeeze your fingers inward, but suddenly you realize your thumbs are completely paralyzed. Like they simply won't move.
Yeah, they just freeze up.
Exactly.
Yeah.
Yet, oddly enough, your pinky fingers work perfectly
It's
fine.
just so strange.
It is. And that bizarre, like, highly specific weakness is the hallmark of a disease that just completely breaks the rules of modern medicine.
It really does throw the rule book out the window.
Right, because usually when we talk about a medical diagnosis involving inflammation, we expect a clean, linear narrative. An intruder arrives, the immune system flares up to fade it, a doctor prescribes a drug to suppress that fire, and then the patient heals.
Well, we crave that cause and effect simplicity in medicine. I mean, we want the mechanism to be visible, and more importantly, we want it to be fixable with a standard protocol.
But then you encounter a condition that forces you to throw out the playbook. Like you look under the microscope, and yes, there's a fire, there is active immune inflammation, but the house is also simultaneously just collapsing from old age.
Yeah, that dual nature makes the diagnostic landscape incredibly murky.
And that's our focus today. Whether you're a medical professional catching up on the latest literature or just someone fascinated by how the human body works, this deep dive is for you. We are unpacking the complexities of inclusion, body myositis, or IBM.
And we're anchoring this on a phenomenal comprehensive review authored by Dr. Eli Nadav, which was published in the neurology journal Continuum.
It's a great paper. So let's start with a high-level view. What are we dealing with here?
So, to frame the scale of this, IBM is actually the most common muscle disease, or myopathy, in adults over the age of 50.
Oh, wow.
Yeah, it affects roughly 77 out of every 1 million people in that demographic.
And that demographic profile actually holds a massive twist that caught my eye immediately.
Right, the gender flip.
Exactly.
Hmm.
Whenever we dive into immune-mediated diseases or autoimmune conditions like lupus or rheumatoid arthritis, the statistics skew heavily female. But IBM flips that entirely on its head. It affects males twice as often as females.
Which is fascinating. That demographic flip is really our very first clue that IBM is not operating like a standard inflammatory myopathy.
Right.
It behaves differently from day one, defying those typical hormonal and genetic patterns we, usually associate with autoimmunity.
Okay, so before we get into the microscopic details of why the immune system is acting so strangely, we need to picture what this looks like in the real world. Like when a patient actually struggles to walk into a clinic.
The signature weakness.
Yeah. The thumb paralysis we talked about at the top is such a striking visual. And it's not just a general weakness in the hand, right? It's a very localized failure.
Exactly. Doctors actually have to test the fingers individually.
Because the gross grip strength might seem okay at first glance.
Right. If you just ask them to squeeze your hand, they might compensate. But the muscle controlling that specific thumb movement, the flexor pollicis longus, it just stops responding.
Which is wild, so it's very targeted.
It is, and it really highlights the asymmetric, slowly progressive nature of the disease. Like, a patient might have severe thumb weakness in their right hand, while their left hand shows weakness in the index finger instead.
Or maybe no significant weakness in the left hand at all.
Exactly. It's just this chaotic map of deterioration.
But, while the thumb weakness is fascinating, the reality of daily life really hinges on a different muscle group entirely.
The quadriceps.
Right, the knees.
Yeah, the knee extensors bear the absolute brunt of this disease. And it's tricky because the quadriceps are the largest and strongest muscles in the human body.
Which paradoxically masks the early stages of IBM, right?
Yes, exactly. Because of that immense reserve of sheer strength, a patient won't even notice a 10 or even 20% drop in quad strength when they're just, walking to the kitchen or standing at a counter.
Yeah. It's only exposed when they demand the absolute maximum from that muscle.
Precisely.
Like being asked to kneel down on one knee and then trying to stand back up without using their arms to push off. And suddenly, the leg just buckles. I mean, I can't imagine the psychological toll of realizing your largest muscle group has just secretly hollowed out like that.
It's terrifying. The loss of that structural reserve is devastating, and once the knee extensors deteriorate, the ankle dorsiflexors usually follow.
So it moves down the leg.
Yeah, that specific downward trajectory is why, on average, patients with IBM lose ambulation and require a wheelchair within a decade of their symptom onset.
Man. You'd think a phenotype that specific, the paralyzed thumb, the hollowing quad, the asymmetric progression, You'd think that would make this an easy day one diagnosis.
You really would.
Yet patients often spend years in a diagnostic purgatory, constantly misdiagnosed by different specialists.
Why
Why is that?
Well, the clinical reality is that diseases rarely read the textbooks.
Huh, fair point.
While that thumb and quad presentation is the classic phenotype, roughly 14% of patients fall into an atypical category that sends neurologists down entirely wrong paths.
Right, and Dr. Naddaff's review catalogs a few of these atypical presentations, like head drop, which is severe axial weakness in the neck.
Which is very disorienting for a clinician to see.
I bet. Or foot drop, or even facial diplegia, where the facial muscles lose their tone. But the one that stopped me in my tracks was isolated dysphagia.
Difficulty swallowing.
Right. I mean, wait, we just went from a muscle disease attacking the knees and the thumbs to one attacking the throat. My first thought is, like, do these muscles share a specific motor neuron type, or is there some developmental link? How does a disease in the legs jump to the esophagus?
It's a great question, and honestly, the connection between limb muscles and bulbar muscles, those are the muscles controlled by the lower cranial nerves that handle swallowing. It remains one of the great unsolved mysteries of IBM.
Really? Still unsolved?
Yeah. There are theories about shared protein expressions or specific cellular vulnerabilities, but the biological why is still pretty elusive. What we do know, unfortunately, is the devastating what. In some patients, particularly females, this dysphagia can be the very first symptom that appears, long before the legs give out.
And difficulty swallowing isn't just a quality of life issue, it's an immediate threat to life.
Absolutely. Dysphagia leads directly to aspiration. Food, liquid, or even simply saliva bypasses the weakened throat muscles and enters the airway and lungs instead of the stomach.
Which causes aspiration pneumonia.
Exactly. And that is actually one of the leading causes of death for IBM patients. The limb weakness steals their mobility, but the bulbar weakness is what ultimately threatens their survival.
It's just so brutal. To understand why this disease is destroying these seemingly unrelated muscle groups, we really have to zoom in. We have to leave the macro level of the patient's body and look directly at the tissue under a microscope.
Yeah, a muscle biopsy remains the absolute cornerstone of an IBM diagnosis. Even with all the modern imaging and blood work available today, visualizing the tissue pathology is mandatory.
So what are they looking for?
Well, when pathologists examine an IBM muscle biopsy, they are hunting for 3 canonical features that define the disease.
Okay, let's break these down, starting with the fire we mentioned earlier, the autoaggressive inflammation.
Right. The pathology slides reveal a very specific type of immune invasion. We see CD8 positive T cells, which are cytotoxic cells designed to destroy infected or cancerous tissue swarming and actively invading muscle fibers that are otherwise completely healthy.
Which is wild. And these aren't just random immune cells, right?
No, not at all. They are clonally restricted and highly differentiated.
Basically, they're rogue assassins. The immune system's elite killers have basically lost their tolerance and decided the healthy muscle tissue is the enemy. I'd imagine this is tied to immunosenescence.
Yes, exactly.
Like the natural aging of the immune system where it starts making these catastrophic targeting errors.
Immunosenescence is definitely a leading theory for why these specific T cells go rogue. As the immune system ages, it loses its regulatory oversight. But the inflammation is only the first feature.
Right, there are 3.
The second canonical feature is mitochondrial dysfunction.
Okay.
Staining the biopsy tissue reveals muscle fibers that are completely negative for an enzyme called cytochrome C oxidase.
Which means the mitochondria, the literal energy powerhouses of the cells, are failing.
They are. The engines are shutting down.
And that points away from simple inflammation and points directly toward aging and degeneration.
Exactly. And that mitochondrial failure bridges us to the third and most revealing feature of the biopsy, the severe accumulation of autophagic rimmed vacuoles and protein aggregates inside the muscle fibers.
This is the part of the biology that I find completely mind-blowing. It's like the cell's internal garbage disposal system just breaks down.
That's a perfect way to describe it.
The muscle fiber literally turns into a microscopic hoarder's house, piling up cellular trash it can no longer recycle. And the specific proteins piling up, things like P62, TDP43, and amyloid, those are the exact same proteins we constantly talk about in neurodegenerative diseases.
I know, seeing brain aging pathology happening inside the skeletal muscle of the legs and arms is just a profound biological crossover.
It really is.
I mean, amyloid plaques and TDP-43 aggregates are the defining pathological features of Alzheimer's disease, Parkinson's disease, and ALS. Finding them in a thigh muscle forces us to reconsider the fundamental nature of the disease.
It perfectly frames the massive debate going on in neurology right now.
Oh, the chicken or egg debate.
Yeah. Like, is IBM primarily an inflammatory autoimmune disease that happens to cause a secondary buildup of protein garbage? Or is it primarily a degenerative disease of aging, a breakdown of cellular recycling that subsequently triggers those CD8 T cells to attack the failing hoarded cells?
The fire versus the collapsing house.
Exactly. Which came first?
And because IBM masquerades as both, the medical field has historically struggled to standardize the diagnosis. If a clinician focuses only on the inflammatory assassins, they misdiagnose it as a more common treatable condition like polymyositis.
And that misdiagnosis is exactly what the new 2024 European Neuromuscular Center, or ENMC, diagnostic criteria are designed to prevent.
Right, they modernize the entire framework.
Moving away from incredibly rigid rules like strict age cutoffs or strict thresholds for creatine kinase in the blood, and formally incorporating newer diagnostic tools.
The 2024 criteria represent a necessary evolution. They recognize that biological aging and disease onset don't follow a strict calendar.
Right.
By removing those rigid cutoffs, they rely more heavily on specific blood markers and advanced imaging.
Well, I do want to push back a little on the blood marker they included, the CN1A antibody.
Oh, sure.
Because, I mean, you'd think finding a specific antibody in the blood would be the ultimate silver bullet, right?
Mhm.
You draw the blood, you see the antibody, boom, you have IBM. But looking closely at Dr. Nedaf's review, the medical community is treating it with extreme caution.
Very much so.
It's apparently far less specific than anyone hoped when it was first discovered.
Yeah. The initial excitement around the CN1A antibody has definitely been tempered by clinical reality. While roughly half of IBM patients do have this antibody circulating in their blood, it also shows up in patients with other autoimmune diseases.
Like Sjogren syndrome or lupus.
Exactly. Patients who have absolutely no muscle disease. So it serves as a supportive clue in the broader puzzle, but it cannot stand alone as a definitive answer.
So because the blood test isn't a silver bullet, neurologists have had to rely heavily on imaging. And what shows up on a muscle MRI is fascinating.
It's very visually distinct.
They look for T1 hyperintensity, which basically means the muscle tissue shines brightly on the scan because the healthy muscle has been completely replaced by fat. I always wonder about the mechanics of that. Like, does the muscle cell literally undergo some kind of alchemy and turn into a fat cell?
Oh, no, the transformation is structural, not alchemical. The muscle cells themselves die and become necrotic.
Okay.
Then the body's cleanup crews, the macrophages, clear away that dead tissue. To maintain the physical integrity and shape of the limb, specialized cells called fibroadipogenic progenitors rush in.
That is a mouthful.
It is. But basically, they fill the empty void with adipose tissue, or fat.
So it's essentially using fat cells of biological spackle to fill in the holes where the muscle used to be.
Biological spackle is a great way to visualize it, and the pattern of where this spackle is applied gives IBM away.
Right, because it's not random.
No. The MRI will show severe fatty replacement in the distal vastus medialis and the vastus lateralis, so the outer and inner parts of the quadriceps, along with the medial gastrocnemius in the calf.
But astonishingly, it almost completely spares the rectus femoris, the muscle sitting right dead center in the middle of the thigh.
Which is so bizarre to see on a scan.
I mean, the muscle right next door is completely hollowed out and filled with fat, but the rectus femoris is perfectly fine. Is that like a vascular supply thing or just different biomechanical stress?
It is another layer of the IBM mystery, honestly.
Ah.
Biomechanical stress and differing muscle fiber types are the leading hypotheses right now, but we don't have a definitive answer for why that central muscle is spared.
Wow.
What we do know is that the visual contrast on the scan is striking. Diagnosing IBM under the 2024 criteria requires a sophisticated blending of all these elements: the clinical phenotype of the thumb and knee, the highly specific MRI fatty replacement pattern, and the definitive proof of the hoarder's house and rogue T cells from the biopsy.
Okay, so the patient finally navigates this entire labyrinth. They get the MRI, they endure the biopsy, they get the blood work. The neurologist sits them down and says, we finally have the answer. It's inclusion body myositis.
It's a heavy moment.
Yeah. And the natural instinct for any patient in that chair is to ask for the cure. Like, what pill do I take?
Right.
But because this disease masquerades as standard inflammation, the treatments we usually reach for actually become a trap.
Delivering the diagnosis is a devastating conversation because currently there is zero evidence-based pharmacological treatment for IBM.
Zero.
None. And the paradox is that because it looks so much like other inflammatory myopathies, the knee-jerk reaction in medicine for decades was to treat it with heavy, blunt force inflammatory treatments.
Like high-dose corticosteroids.
Exactly. Prednisone or powerful broad-spectrum immunosuppressants.
Basically throwing massive amounts of water on the fire.
Yeah.
But if we think back to the biology, if this is heavily driven by aging and a collapsing cellular infrastructure suppressing an already senescent immune system with toxic steroids, is just adding fuel to the fire?
You hit the nail on the head. The clinical data backs up that exact logic. Not only do these standard drugs fail to halt the progressive weakness, but treating IBM patients with toxic immunosuppressants actively makes their long-term outcomes worse.
That is so frustrating.
It is. You are exposing an aging patient to severe side effects, bone loss, catastrophic weight gain, diabetes, and a high risk of opportunistic infections for absolutely zero clinical benefit.
So if the standard pills are dangerous and there's no pharmacological cure, the immediate question is how you actually help the patient sitting in the exam room. What do you do?
Well, the medical strategy completely shifts from a pharmacological attempt at a cure to a highly aggressive, multidisciplinary management approach. The focus is entirely on anticipating the complications and preserving the patient's quality of life.
Based on the lethal risk of aspiration pneumonia we discussed earlier, managing the dysphagia has to be at the absolute top of the list.
100%.
Speech therapists become crucial here, teaching compensatory swallowing techniques. But Dr. Nadaf's review also details a surgical intervention for severe cases, which is a cricopharyngeal myotomy. I was reading about this, and it sounds incredibly intense.
It is a major procedure.
I mean, to surgically cut a throat muscle just to allow food to pass.
Yeah, it sounds extreme, but the anatomy makes it a necessary intervention for some.
How does it work?
The cricopharyngeus is a muscle at the top of the esophagus that functions as a tight valve. Normal swallowing generates enough pressure to push food past that valve.
Okay, so it opens under pressure.
Right. But in IBM, the throat muscles become so weak they can't generate the required pressure. So the food pools in the throat, leading to choking.
Oh, I see.
So myotomy literally cuts that specific sphincter muscle, releasing the permanent tension.
So it's a mechanical fix for a muscular failure. You essentially break the door off the hinges so the food can just fall down the esophagus via gravity.
That's a great analogy. And it drastically reduces the risk of aspiration. Beyond surgical and speech interventions, patients also require sleep medicine specialists.
Because the respiratory muscles weaken.
Yes, eventually causing sleep-disordered breathing. And of course, physical therapy is paramount. The goal of PT isn't to magically reverse the muscle loss, which is impossible, but to teach the patient how to safely use assistive devices.
And maximize the strength in the muscles that the disease has spared, like that rectus femoris we talked about.
Exactly.
So you're essentially building a fortress of support specialists around the patient to keep them safe as the structure slowly weakens.
That's the current reality, yes.
But looking at the current clinical trials, the scientific community hasn't given up. They are finally developing therapies that target the highly specific mechanisms of IBM rather than just carpet bombing the immune system with steroids.
Yes, the paradigm shift in research is incredibly promising.
2 drugs in particular are stepping into the spotlight.
Right. Ulvaprubart is the first major drug currently in trials. It's a monoclonal antibody specifically designed to address those rogue, highly differentiated CD8 T cells we saw in the biopsy.
The assassins.
Yes.
I remember reading that those specific cells express a unique KLRG1 protein on their surface. That's what makes them so stubborn, right?
Yeah.
They essentially have a shield that allows them to escape normal, broad-spectrum immunosuppressants.
That KLRG1 marker is their defining feature, and Ulvaprubart is engineered to act as a smart bomb, seeking out and neutralizing only the immune cells that display that specific KLRG1 protein.
That's brilliant.
It is. It leaves the rest of the patient's immune system completely intact to fight off normal infections while specifically halting the autoaggressive inflammation in the muscle.
Wow. So that addresses the fire side of the debate. But the second drug in the spotlight, sirolimus, attacks the other side of the IBM coin. the collapsing house of degeneration.
Right. Sirolimus is an mTOR inhibitor.
Based on how mTOR pathways regulate cellular metabolism, I'm assuming this drug is designed to manually override the cell and jumpstart that brick and garbage disposal system.
Exactly. Inhibiting the mTOR pathway forces the muscle cell into a state of heightened autophagy. It tricks the cell's internal recycling centers into aggressively cleaning up and digesting all those accumulated toxic proteins, the amyloid and the TDP-43 that are creating the rimmed vacuoles.
So it's an eviction notice for the microscopic hoarder's house.
Perfectly said. We are currently waiting on the final phase 3 trial results for both of these drugs, but regardless of the immediate outcome, they represent the first generation of therapies that actually respect the complex, dual nature of the disease.
Bringing this all together, inclusion body myositis is just a masterclass in medical deception. It mimics classic inflammation, but operates with the slow, relentless, degenerative mechanisms of aging.
It really is a wolf in sheep's clothing.
Yeah. It uniquely targets our grips, paralyzing our thumbs while ignoring our pinkies. It attacks our stance by hollowing out the quadriceps and filling them with fat, and terrifyingly, it threatens our very breath by paralyzing our throat.
And for anyone listening, whether you are a clinician evaluating a complex patient or someone advocating for a family member's health, recognizing these highly specific patterns is the difference between a managed decline and active harm.
Because of the steroids.
Exactly. A delayed diagnosis is unfortunate, but a misdiagnosis is dangerous. Mistaking IBM for generic myositis leads to the prescription of heavy, toxic steroids that will accelerate the patient's physical decline. Understanding the nuances, the asymmetric weakness, the specific MRI fatty replacement, the unique biopsy findings of KLRG1 cells and protein garbage, it's the only way to navigate this labyrinth safely.
It really emphasizes how precision in the initial diagnosis is just as vital as the treatment itself. And it leaves me with this final thought.
Go for it.
If IBM is, at its biological core, a disease of aging where protein homeostasis breaks down, well, if it shares the exact same cellular garbage, the amyloid and TDP-43 proteins, as Alzheimer's and Parkinson's, it completely shatters the walls between medical disciplines.
It really does blur the lines.
Right. Like, could a massive breakthrough in the neurology of dementia inadvertently hand us the cure for this muscular disease? I mean, as researchers pour billions of dollars into unlocking the secrets of aging in the brain, they might just find the exact key we need to save our muscles in the process.
The pathology connects the brain and the brawn in ways we are only just beginning to understand. It's a very hopeful thought.
Thanks for joining us on this deep dive. We'll catch you on the next one.